I would like to call Dr. Anup also on the dais.
So, Vince is going to enlighten us about that. So, we will start the fourth session, that is anatomical considerations in THR. So, may I call upon Dr. Sudeep Kumar, who will be talking on does femoral head size matter? Bearing surface in THR gold standard. Dr. Sudeep.
Thank you. Good afternoon. So I will be now talking about femoral size and which size fits the best to all. Okay, it's a slightly contradictory statement. There is no one size can fit all. As compared to the bearing surface, probably we have an idea which bearing surface is working for all. But what size should fit all? Let's see. Okay, so 5 seconds of no conflict of interest relevant to this talk. We have a lot of things in the market, and we have high expectations from our patient in India. Those who are following this news lately in India, we know that there is a lot of backlashing and everything for the doctors. Okay, so we have a high burden of failure, and we have to avoid all kinds of stuffs are there. What we want is an optimized function, maximized survivorship, and an accelerated recovery. This is what we are trying to achieve in all our patients every single day. So we need to succeed in every patient, right? Then we have known that time for bearing surface has a huge bearing on how your patient is going to work, how it's going to survive. And metal on poly, ceramic on poly, ceramic on ceramic are the three common bearing surfaces that are being used nowadays, but I'm not going into the extreme detail into it. But we know for sure now is that the highly cross-linked polyethylene is the one polyethylene that you should be using as compared to ultra-high molecular weight polyethylene. Okay. Ceramic, of course, is giving very good results across registries, and this new third generation, this Biolox Delta, ammonia composite, alumina and zirconia composite ceramic is the one which has shown the best results across the literature and across the registries. Having this background, how does the head size come into picture? So head size come into picture is in the way that it gives you a stability and prevents dislocation. It depends if you're using a big head size, probably it will give you a more wear of your bearing surface, range of movement, impingement, gait pattern and function output. So in effect, head size affects all these things. So whatever head size you're choosing, it should give you good results in all these parameters. Let's see each one of them briefly. So we know that loosening, dislocation are the most common modes of failure of any total hip replacement. Okay. So as compared to the dislocation, does head size what does the literature has left for us? So this one from the 42,379 primary procedures from a Finnish arthroplasty registry. And what they found is that 28 mm of head size has a 10-fold higher risk of reoperation due to dislocation. So that's a very big number of paper on a 28 mm size. Okay. Now there is an Indian paper I have brought in here which also suggests that 28 mm head size has a higher dislocation rate when it compared to a 32 mm head size. Again, a Nordic arthroplasty registry says that there was a lot of things in this, but they also suggest that 32 mm head size would give an overall better results as far as dislocation is concerned. And the measurement of impact of femoral head size on dislocation published in Hip and Pelvis in 2017. It says definitely head size does matter, but there are a lot of other things which are more important when you're seeing dislocations, like if the habitual alcohol intake and other neuropsychiatric disorders. These two factors contribute much more than head size when you are seeing at the dislocation. So in a nutshell, what we see is that 28 mm head size has definitely higher rates of dislocation if you see across the paper, and 32 mm head size and more probably decreases the dislocation. Alright. does this have any bearing on the gender? So does male and female all 28 mm head dislocates, or they have a higher rates of dislocation? Probably not. In this paper, journal published in Journal of Arthroplasty, they suggested that the 28 mm head size in females has a better dislocation rate as compared to any other head size. Okay? So there are caveats, and you need to know what fits well to your patient. Right. Now, does your head size, and we know that we are putting 20, 30, 28, 32, 36 mm head, and they are supposed to replace a 48, 52 mm native head. And they are not, that is where the concept of big head size and large metal on metal head came in, metal on metal surface came into picture, that it replicates the normal body movements and a normal femoral head. Does it has any effect on the movement? So one paper published in Journal Sensor in 2019, and they measured all kind of movement of the pelvis before and after surgery in 2 or 3 different groups. One was with a conventional head size, and other was from the larger femoral head. Larger means 36 and 40, and the normal means 32 and 28. And they didn't find any difference in pelvic movement or the gait pattern. There are other papers as well, like the one published in CORR. It was a prospective randomized control trial, and they mentioned that they thought that the larger head will replicate the Leica normal head and will have a better gait recovery. But they found no clinical difference in the gait recovery after 2 months or 4 months after the surgery. Though a small follow-up, but a randomized trial, and it has bearing on some of the information that we'll take home today. Right. So again, now with the small head, what we say is that it will impinge. The small head-neck ratio will get short, and the neck will impinge on the liner or the...
Because sometimes there can be bleeders which shift to the TAL.
Increasing the head size decreases the impingement. So this paper published in Fifth International in 2012, it shows that it does have some decrease in the impingement as you increase the head size. But that decrease in impingement by increasing the head size is not linear. So it does not mean that if you are increasing the head from 28 to 32, 32 to 36, the proportionate increase in head size will proportionately increase the decrease in impingement. It has some advantage, but not a huge advantage. So that is, it definitely does have some improvement in impingement. Okay, and then this paper again published in Hip International in 2017. This also shows that the impingement, which is 50% in 28 mm head, reduced to 21% in 36 mm head, and 15% of the liners in 32 mm head. So it shows that quite a change from 28 to 36, that's a high impingement, and 32 mm head has the least impingement. Okay, so 32 is coming into picture and is being focused time and time again. Okay, and of course the nutshell is that the larger head, they do reduce impingement, but not to a greater extent. Right. What is the functional outcome after total hip replacement as you go on increasing the head? And this literature published in Journal of Arthroplasty in 2014, it does not suggest that if we keep on increasing the head size, you're going to get a good functional outcome. And again, another report published in Hip International in 2012, they also just suggest that as you go on increasing the head size, it does not mean that you're going to get the good functional outcome. Then a study from patient-specific hip geometry on femoral head size, they shows that 32 mm head resulted in lowest amount of wear as compared to 28 mm, because if you increase the head, what will happen is that you will decrease, your liner will get thinner and thinner, and the wear rate will increase. So overall, the 32 mm head in this paper published shows that the least wear amount in 32 mm head. Now, after seeing the dislocation rate, the impingement, the gait pattern, and the functional outcome, we see what the registries are telling, what countries who are registering their hip replacements are doing, and what is their trend. So you see in the slide here, most of, except the Denmark, which is using 36 mm head, most of these countries are using 32 mm head. And this is more relevant in Indian scenario, probably in eastern zone, where the patient population is not more than, or an average height of the patient will be 5.5 feet. Probably not getting a huge patients like we get in western part of and northern part of our country. Probably will be better off using a 32 mm head or a 28 mm head rather than going up on 36 and a 40 mm head. So American, they are using more and more of 36 mm heads and 40 mm heads, and less of 32 mm heads and 28 mm heads. But wherever they are using highly cross-linked poly, the ceramic head is their head of choice, not the metal. And again, Dr. Maheshwari's same 2019-16 annual report of National Joint Registries, very interesting. The cemented total hip replacement, the worst failure rate was for 32 mm head. Both in the metal head, the worst failure rate was of both in cemented and in uncemented 32 mm head. And when you see the uncemented head, you will find that the 32 mm head, like ceramic uncemented, the ceramic head, the best survival was of 32 mm head. So the metal head, if you're using, probably the worst results are with the 32 mm head, and when you're using ceramic head, the best results are with the 32 mm head. So that's two contradictory reports are coming from a huge registry in England and Wales. Okay, so that has to be kept in mind. What material you're using, that will determine what size you should be using. Okay. So again, the same thing. Again, the Norwegian Joint Registry, there also 32 mm head has shown the best results across the years, 10 years follow-up. And Swedish Joint Registry also shows that the 32, the increase in the number, the green one here, is the increase in the number of the 32 mm head over last 6-7 years as compared to any other head. Again, in the New Zealand Joint Registries also shows that the increase in the number of 32 mm head as compared to any other head. And interesting is that their rate of revision is much less in 32 mm head, no matter whether you're using a metal head or a ceramic head in New Zealand Joint Registry. Okay. And the Australian Joint Registry also kind of 32 mm head is showing the best results. But of course, they are showing best results in highly cross-linked polyethylene, and that's probably the only registry which is showing that ceramic on ceramic is doing the best for last 15 years overall. And the test registries also that 32 mm head suggests that the 32 mm head has the better results in wear rate, in dislocation rate, and the overall survivorship. Okay, so what is the take-home message? I've given you so much of literature and data. Probably 32 mm head is probably the ideal size. Of course, I can't give a verdict on 32 mm, 36 or 28, but definitely there is no merit in increasing the diameter if you want to achieve any of these parameters. If you just think that you are going to achieve a lesser dislocation rate, lesser wear rate, lesser good function, probably just by increasing the head size, it's not going to work. Okay, in selected cases like female and metal and poly, probably there is a merit in using a lesser and lesser diameter head. Probably 28 mm is the head that you should be using. Ceramic on highly cross-linked poly is the probably bearing surface of choice. And if you're using metal, then of course definitely highly cross-linked poly is the bearing surface has to be done. So a lot of issues, lot of data. Patient will hide a lot of things. You have to give your best. You need to have a good team, and nothing works better than a good team working with you. Thank you very much.
Thank you, Sudeep, for clearing a lot of doubts about the heads. What goes into the heads we have to see, and what we are using, it's most of it is with the practice and your experience as it goes. So any questions for Dr. Sudeep? So we have talked about the size of the heads and the surface. Yeah.
Sir, very, very nice paper. I have a doubt there. Sometimes the size of the head is also dictated by the size of the socket. And in our patients, a lot of our sockets are not big enough to accommodate 32.
Definitely. So that's what I said, that sockets are not big enough, but at least 28 mm is the one that is, if you go beyond 44 and 46, 44 mm head, probably 28 mm is the head that you can always use. But if you go beyond 50 and 52, many companies will offer you 32, and some companies will offer you 36 when you go beyond 52 and 54. And that is where your choice of head will come into picture. You have the option of using 32 and 36 both. But when you have no choice, like if you're going below 48 or 46 or 44, probably you won't be able to use 32.
Yeah, the newer cross-link poly, some of these companies are offering 32 heads with 48 size.
Yeah, that's where the choice, that's where these papers come into picture. Probably in a female patient, definitely use a 28 mm head size. They have 28 mm head size as well. And with male, probably younger male, you can go for 32 mm head size. That's what I can give you my 2 penny worth of thought.
If you go with a 32 and a 48, always use a ceramic.
Yeah, that's what. Ceramic head. If you're going with 32, you have on a smaller head cup size, so ceramic is the head that you should be using.
Somewhat similar is this. A study where you showed that in certain women, 28 heads. Is it more related to the size of the
size of the socket?
Socket rather than
yes.
anything else? So
no, it's
if
just
you have a socket size beyond 48 or 50, maybe 32 is better, but below that maybe 28 is better.
28 is better.
And if you look at India, maybe some of the men have sizes which are 48.
Smaller, yes.
So,
there is literature which says that if the inclination is beyond 50 degrees, you should be using a 20, or if the acetabulum is very deformed, you better use a 28 mm head.
32, yeah. Okay.
And those studies are not published in India. So
I think dislocation rates again is more related to version,
so many
tissue
factors,
balancing, length, etc. than anything else.
So with that, we close the session. Thank you.
Thank you, everyone.
Dr. Rajivan, kindly. Sudeep, sir. Dr. Riteshun, can we facilitate Dr. Rajivan as the chairperson? John sir, kindly facilitate Dr. Rakesh Chaudhary sir. Dr. Mukherjee, kindly facilitate Dr. Rakesh Chaudhary sir.